Welcome to Weekly Neurology Deep Dive. Today, we're diving into the 2024 Association of British Neurologists Guidance on Disease-Modifying Therapies for Multiple Sclerosis. This deep dive is purely for educational purposes and provides only a summary. You will want to consult the full paper in Practical Neurology for complete information. We're going to focus on the data and practical takeaways you can use in your daily clinical practice.
The ABN emphasizes that MS should be considered a single disease with fluctuating, relapsing, and progressive components. This challenges the traditional subtyping of the disease and could impact how neurologists approach diagnosis and treatment moving forward.
How does this new understanding affect the definition of active disease?
The guidance recommends including radiological evidence into the definition of active disease. New or enhancing lesions on MRI should be considered signs of disease activity, even without clinical relapses. This is a change from relying solely on clinical relapses, which could delay treatment.
The ABN guidance strongly recommends offering DMTs as early as possible to eligible patients with active disease. It even suggests high-efficacy therapy as a first-line option, potentially within 2 years of disease onset. This represents a departure from the traditional escalation approach. What should neurologists consider when making these decisions?
Shared decision-making is crucial. DMT selection should involve a collaborative discussion weighing the patient's disease activity, prognosis, risk tolerance, lifestyle, and even future family plans. This personalized approach is at the heart of the recommendations.
The ABN guidance aligns with the latest international recommendations on using MRI as a key tool to monitor treatment effectiveness. What are the practical implications for neurologists?
Annual brain MRIs are advised for all patients on DMTs to monitor disease activity. After 5 years, the frequency of MRIs may be adjusted based on individual risk and disease stability. Robust safety monitoring protocols are also emphasized, particularly for DMTs with specific risks, such as progressive multifocal leukoencephalopathy or PML.
Let's talk about switching DMTs, which is becoming more common in clinical practice. What are the ABN's specific recommendations in this area?
The guidance emphasizes the concept of therapeutic lag. It suggests giving a new DMT at least 6 months before considering a switch due to efficacy concerns, assuming it's well tolerated.
What if there are signs of breakthrough disease activity despite the DMT?
The guidance recommends considering escalation to a higher efficacy therapy after a clinical relapse. On the MRI front, 2 or more new T2 brain lesions or 1 new spinal cord lesion should trigger a conversation about potentially intensifying treatment.
The guidance also addresses discontinuing or de-escalating DMTs. Does it support setting arbitrary time limits on DMT use?
No, it encourages ongoing discussions with patients about long-term treatment plans, including the possibility of an exit strategy if the risk of inflammatory activity is deemed low. Factors like disease duration, phenotype, age, and disability level should all be considered when discussing potential de-escalation or discontinuation. Any patient making such a change needs to be monitored closely for any signs of disease reactivation.
Pregnancy and DMTs are an important consideration for many patients. What are some key takeaways from the ABN guidance in this area?
The guidance emphasizes integrating family planning discussions into routine MS care, meaning proactively talking to patients about their reproductive goals and how DMTs might affect those goals. Women should never be denied or discouraged from treatment simply because of potential pregnancy plans. The guidance also stresses the need for flexibility in switching DMTs to enable women to access therapies with a more favorable safety profile during pregnancy. They are also supportive of women continuing appropriate DMTs while breastfeeding if necessary and safe.
The ABN guidance also addresses the important topic of equitable access to DMTs. What are some of their key recommendations in this area?
The ABN makes a strong statement about the need for sufficient funding and integrated pathways to ensure timely access to appropriate DMTs for all eligible patients. Regardless of their background or location, they point out that the current shift from national to local commissioning of MS services in England poses a potential risk to equitable access.
What about autologous hematopoietic stem cell transplantation, or AHSCT, as a treatment option for MS?
The ABN expresses support for the appropriate use of AHSCT and advocates for wider availability of this treatment within the UK, provided that agreed criteria for site qualification are met. Currently, AHSCT is offered on the NHS only to people with treatment-resistant inflammatory active MSY, following guidelines from the European Group for Blood and Marrow Transplantation.
The guidance also highlights some important areas for future research.
One priority is determining the long-term risk-benefit balance of DMTs, particularly for patients who have been stable for several years. Further research is needed to understand when and how to safely de-escalate or discontinue treatment without jeopardizing long-term outcomes.
Are there other research areas the ABN has identified as needing further investigation?
The ABN emphasizes the need for research to develop biomarkers that can detect worsening MS pathology, especially in patients with disability progression but no new MRI activity. This could allow for treatment adjustments even if their MRIs appear stable. They also advocate for more research focusing on often overlooked disabling symptoms, such as upper limb dysfunction, cognitive impairment, and fatigue. These symptoms can have a significant impact on quality of life.
The ABN guidance doesn't shy away from the more challenging aspects of MS treatment. They address the issue of treatment inertia. Can you explain what they mean by that?
Treatment inertia refers to the reluctance to change a patient's treatment plan even when it may not be working optimally. The guidance encourages neurologists to be proactive in monitoring treatment effectiveness and adjusting the plan if necessary.
The guidance provides specific recommendations for when to consider escalating therapy based on MRI activity. They're urging neurologists to move beyond just clinical relapses as the sole trigger for treatment changes.
The ABN also reiterates the importance of multidisciplinary care in MS management. They specifically mention that MS specialist consultant neurologists, specialist MS nurses, and neuroradiology expertise should all be involved when making decisions about DMTs. This is especially true in complex cases or when considering high-efficacy therapies.
What does the ABN recommend regarding the use of generics and biosimilars?
The guidance advocates for using generics and biosimilars when they offer cost savings without compromising patient care. They emphasize that the same level of service and support provided for the initial prescription of a DMT should also be available when prescribing generics or biosimilars.
NED3, or no evidence of disease activity, has been getting a lot of attention in MS management lately. Does the ABN guidance address this concept?
They point out that no DMT can completely eliminate the risk of disease activity. While striving for NED3 is a good goal, it's important to have realistic expectations. Some patients might experience minimal disease activity even on treatment. They note that a new T2 lesion on MRI without contrast enhancement, in the absence of relapses, might be acceptable in some cases, but this requires careful monitoring and further research.
The guidance also delves into the complexities of switching DMTs due to factors other than disease activity, such as tolerability or safety concerns. What are some of their recommendations?
The ABN recommends switching to a DMT with at least similar efficacy to the one being discontinued. For instance, if a patient has side effects from a high-efficacy DMT, they should be able to switch to another high-efficacy DMT rather than stepping down to a less potent therapy. The guidance also highlights the importance of carefully managing the transition between DMTs, especially when stopping medications that can cause a rebound of disease activity when discontinued.
Can you give some examples of those types of medications?
Natalizumab and fingolimod are prime examples. The guidance recommends keeping treatment gaps to a minimum, typically no more than 4 to 6 weeks, when switching away from these drugs to minimize the window of vulnerability when the immune system is readjusting. They also point out that switching from DMTs with lower rebound risk, such as interferons and glatiramer acetate, might not require a washout period.
We've talked about switching DMTs due to disease activity, tolerability, and safety concerns. What about switching for family planning?
The ABN guidance acknowledges that patients considering pregnancy should have the option of switching to a DMT with a more favorable safety profile, even if their disease is currently stable. They stress the need for flexibility in switching DMTs to accommodate these family planning goals. Women should even have the option of switching to a higher efficacy DMT if it's deemed safer for pregnancy, regardless of their current disease activity level.
It sounds like the ABN is acknowledging that family planning is a deeply personal decision, and that DMT choices should be tailored to individual circumstances and preferences.
That's an important point.
This has been a very informative discussion. Is there anything else about the ABN guidance you think is particularly important for neurologists to be aware of?
Well, they highlight that when switching away from natalizumab, there's an increased risk of rebound disease activity, including the rare occurrence of immune reconstitution inflammatory syndrome, or IRIS.
What are the implications of that for neurologists?
The ABN guidance recommends against interrupting natalizumab treatment for more than 4 weeks. After stopping natalizumab, the guidance advises close monitoring for rebound disease activity, typically with monthly brain MRIs for at least 6 months.
The ABN guidance seems to provide a comprehensive framework for managing DMTs in MS.
It does. It provides neurologists with valuable tools and insights to make informed decisions about DMT use, monitoring, and switching. However, it's important to remember that this is just a summary of the key points. Neurologists should consult the full paper in Practical Neurology for detailed recommendations and guidance.
This deep dive has given us a great deal of information to consider. Thank you for sharing your expertise.
It's been my pleasure.
We'll be back next week with another weekly neurology deep dive, exploring new and intriguing neurological research. Until then, keep those brains buzzing.